Okay. Please don't leave because it's being recorded. All right, guys. So I have a couple lectures and unknown sessions on thyroid because, we see quite a lot of it, and there's a number of things to think about when looking at the molecular testing, looking at the grossing, looking at the histology. So I thought I would start with just kind of a very global approach, like how do we approach thyroid? And then we'll get into some more detailed histology, either at the end of this lecture or at the beginning of next one. Everyone can hear me okay, I assume?
Yep, no issues.
Okay, for some reason I'm like lagging over here. All right, so we're gonna review workup of thyroid nodules. We are going to briefly review some cytologic diagnoses and corresponding possible histologic diagnoses. We're going to identify commercially available molecular tests on thyroid FNA in order to understand their utility in clinical management. And then we're going to discuss various grossing techniques sort of based on the cytologic or FNA diagnosis and the reasons behind them. If time allows, at the end of today, we'll do some histology slides. And just as a reminder, my other thyroid videos on my YouTube channel are linked there. So to remind us, development of thyroid, of the follicular cells of the thyroid, starts at the base of tongue at the foramen cecum as a condensation of endoderm. It migrates down the anterior midline of the neck within the thyroglossal duct. So there's like a tube in which it travels. It solidifies and divides into the bilateral lobes connected by the isthmus across the trachea. Remember, because it descends down the midline, it may leave little drippings like a pyramidal lobe or even a cystically dilated thyroglossal duct remnant, i.e. a thyroglossal duct cyst. Some studies have estimated that more than half of the population has thyroid nodules, so quite prominent. Mostly they are benign, but of course they can certainly be malignant. These nodules tend to be identified either by palpation or visualization by the patient themselves, as you can see on this woman's neck. Palpation on physical exam by the doctor actually definitely catches some cancers. And as we know, people are getting imaged for various reasons. So ultrasound of the neck or CT or MRI for non-thyroid reasons in which the thyroid is visualized can certainly pick up a thyroid nodule, and then it requires a workup, right? And so we're detecting a lot of nodules in general clinical practice. The first step once a nodule is identified is dedicated ultrasonographic examination to determine the sonographic features of the nodule and the need for fine needle aspiration biopsy. So FNA is a standard of care, not a core. Some institutions out there still do core biopsy, but any of you who will rotate on the consult service for head and neck will see that these core biopsies are very challenging to interpret, and FNA is certainly better. We prefer that the FNA be directed by ultrasound so that the nodule of interest is targeted. You know that you are in it, and you know that you are not in some other structure of the neck. Certainly, ultrasound guidance is preferred over manual palpation for those reasons. So on ultrasound, there are features that stratify nodules into various risk groups. And so the ATA, the American Thyroid Association, has given us kind of these examples of something from ranging from a very benign cystic hypoechoic lesion on the bottom, very well circumscribed, to things that develop more solid areas, things that develop calcifications, spiculated borders, et cetera. So depending on the ultrasonographic features, the nodules are stratified into risk groups. The ultrasonographic features therefore help determine the need for FNA biopsy. If something is on the higher risk spectrum, it's certainly going to need a biopsy. If something is on the sonographically low risk, they may not even biopsy it. Once it gets a biopsy, the cytologic features on FNA help determine the need for surgery, and we'll go through these Bethesda categories in detail. And of course, once the thyroid gland comes out, the histologic features after resection determine the final diagnosis, because FNA is still just a screening technique. So the goal of that preoperative FNA is to differentiate benign from malignant and guide therapy. So If the patient has a benign FNA and is completely asymptomatic, they will likely undergo observation. Benign with a symptomatic nodule probably will still undergo resection just for alleviation of symptoms, and a malignant diagnosis will certainly undergo resection. But not all FNAs are obviously benign or obviously malignant, and so that's where the Bethesda category comes in. So the Bethesda system sorts FNA findings into categories with increasing risk of malignancy upon surgical resection. And so as you do cytology, you will of course delve more deeply into this. We're just going to sort of dive on a somewhat superficial level. So what I want you to remember is the cytologically indeterminate diagnoses are those that have sort of an intermediate risk of malignancy, anywhere ranging between 10 to 40 to almost 50%. And those are the 3, the 4, and the sometimes 5, right? So 1 is unsatisfactory, 2 is benign, 3 is atypia of undetermined significance or follicular lesion of undetermined significance. We'll go through what that means. 4 is follicular neoplasm / suspicious for follicular neoplasm. 5 is suspicious for malignancy, and 6 is frankly malignant. And so the Bethesda guide says, generally what we see is with this diagnosis, this many percent come out malignant. So I've put the estimated Bethesda rates of malignancy next to our University of Chicago documented historic rates of malignancy. And we are pretty much within range of what is expected. If unsatisfactory, the patient may undergo repeat biopsy. If benign, as I said, only surgery if symptomatic. If indeterminate, right, 3, 4, and sometimes 5, the patient may undergo molecular testing to help additionally risk stratify that patient, or just surgery, diagnostic lobectomy for definitive diagnosis. When do patients undergo a lobe or a hemi versus a total? And so I've listed it at the bottom here. So a lobe is probably when there is an indeterminate nodule and definitive histologic diagnosis is required, or a diagnosis of malignancy, but that malignancy is so small, so low risk that the patient does not need radioactive iodine therapy. The only reason for someone with cancer to get a total thyroidectomy is really treatment of a higher risk carcinoma that does require RAI. So the concept now is minimal in thyroid, meaning there are some countries that essentially don't even biopsy patients with nodules under a centimeter because they know they're such low risk. In our institution, we've stopped doing just frank total thyroidectomies for any diagnosis of malignancy because it spares the patient the need for long-term supplementation, right, with Synthroid. And as I said, the only reason for a total in a cancer patient is to administer radioactive iodine. If you think about it, the thyroid loves iodine, right? It uptakes it. And so if you give RAI to a patient that still has residual normal thyroid, it's going to like suck up all the radioactive iodine and not have as much left for whatever residual cancer might be in the thyroid bed, for whatever might be circulating in the body, right? So the point is to not have that sink, that iodine sink. So you remove the iodine sink, the radioactive iodine can kill all the residual cancer cells. Or most of the residual cancer cells. Okay. But of course, also if you have medical disease like Graves, Hashimoto's, just a very large goiter that's non-responsive to other medical therapy, these patients also can undergo total thyroidectomy. All right, so we'll get a little bit of a thyroid FNA refresher from a so-called honorary cytopathologist, as Dr. Antich sometimes calls me. I'm always happy to look at thyroid, salivary, et cetera, FNAs. So keeps my skills sharp. Does anybody have any questions before we move into the FNAs?
Just out of curiosity, why is it that a core biopsy of the thyroid, I've never seen one, why is it more difficult to interpret than a FNA?
Because a lot of the diagnosis of thyroid depends on the nuclear features. And first of all, of course, the cells on a smear are intact, right? So the nuclei are intact. And the cores are certainly not intact, right? Because you're cutting them like an H&E section. Mm-hmm. And the preservation of the nuclear features in a core is just worse. And so if you think about it, when you're doing a smear, you're basically either just air drying it or immediately like fixing it, right, with the PAP, you know, spray or whatever. In a thyroid core, they're not always equally well fixed or preserved, right? So they can be dangling around in saline, the core itself could be drying, it could be squeezed, you know, by the person with the forceps. And I'm happy to show you guys some core biopsies, but the nuclear features are very, very difficult to interpret, and there's a lot of artifact. And so if you're trying to make a diagnosis of PTC and you want to find an inclusion, like there's a lot of artifactual vacuoles that resemble inclusions. It's very hard to convince yourself sometimes that it could be a real inclusion. So that's why.
Okay.
Yeah. Because I mean, the architecture, right? The architecture is important, but we know that hyperplastic nodules can have papillae. We know that papillary carcinomas can grow in lots of follicles. So it's almost even the architecture that's less crucial, but so it's really, really those nuclei. All right, so we're going to do a little quiz on some of the smears that I show you. So this one is showing sheets of bland follicular cells. Sheets meaning, you know, this large swath kind of honeycomb pattern, and abundant colloid with maybe some scant follicular cells caught in the colloid. So hopefully most of you can identify, yes, that this is in fact, I got 9 out of 9 benign, a colloid nodule, exactly. So what does that look like on histology? So when I see benign colloid nodule on FNA, what am I expecting to see on histology? So usually it's going to be a well-circumscribed lesion with or without a capsule, but certainly well-circumscribed. The follicles are large. There's lots of colloid, and the nuclei are certainly bland, right? So how does that recapitulate? So lots of colloid, absolutely. And those sheets, right, the sheets that we're seeing on the FNA are basically the walls of those large follicles just sort of torn off, right? So they don't actually look like follicles, they look like sheets because the follicles are so large that you're basically only seeing like one wall of that follicle. So this is a perfect correlate between a benign colloid nodule and a quote unquote macrofollicular adenomatous nodule. So why adenomatous? So as those of you who have signed out thyroid with me will know that, you know, we can't always predict neoplasia on histology. So technically adenoma would imply neoplasia, benign, right? In the past, it was thought that these nodules that had, you know, big, lots of colloid, big follicles, they used to be called colloid nodules or hyperplastic nodules. But when clonal studies have been done, it has been shown that some of these are actually clonal. So they are in fact adenomas, but you cannot tell based on the histology. You'd have to do like X inactivation studies or other clonal analysis. Therefore, like it doesn't matter if you're calling it benign, whether you're calling it a neoplasm, a hyperplasm, a colloid nodule doesn't actually matter. So we kind of use the term adenomatous, meaning could be a neoplasm, don't know, doesn't matter. Okay, hopefully that makes sense to clarify why we use that term. All right, here's another example of a smear that has, do I have to share results of that one? Relaunching poll will clear existing poll results, yes. Okay, that has lymphocytes as well as some oncocytic cells. So in what Bethesda category would you put this? The oncocytic cells are kind of in clusters, not really forming really great follicles, not really forming papillae. So some of you who've done cytology before maybe know that this could be, and I'm really lagging here on my computer. I'm really sorry. So some of you said benign, some of you said atypia of undetermined significance, some of you said FLUS. So depending on sort of where your threshold is, all are certainly possible. And this is where correlation with ultrasonographic features might be helpful, right? So if there is a diffusely enlarged thyroid with some vague nodularity, and the patient has a history maybe of some some non-euthyroid, right, some hyperthyroidism, you may actually think that this is just lymphocytic thyroiditis, because we know that in the disease of Hashimoto's, there is diffuse lymphocytic inflammation of the background thyroid, along with oncocytic metaplasia. And that oncocytic metaplasia and nodular thyroiditis often takes the morphology of a vague nodularity, right? So sometimes the nodules in Hashimoto's aren't actually neoplastic nodules. They are actually hyperplastic. And so what do you see on Hashimoto's? You see this nodular cut surface. You see chronic inflammation with germinal centers. You see diffuse oncocytic change of thyroid follicles. So good to all of you who thought that and are writing it in the comments. So just as a reminder, this picture is pretty specific for the medical disease of Hashimoto's, but the medical disease of Hashimoto's is really dependent on the identification of antibodies serologically, because you could have chronic thyroiditis that does not have antibodies. You could have and is usually not oncocytic, right? But that combination of all of the above, the inflammation, the oncocytic metaplasia, and the antibodies is quite specific for Hashimoto's. So just a reminder of oncocytes, these are metaplastic changes in various organs. When oncocytes are seen in the thyroid, they can be called Hürthle cells, after the guy who may or may not have described them in the past. They have abundant eosinophilic cytoplasm, which is granular because of the mitochondria, as you can see on the electron microscopic images, large nuclei, prominent nucleoli, because they are kind of metabolically very active cells. Okay. You guys are saying we should answer all questions with what is. All right. Next one. So relaunch poll number 1. This is an FNA that may have some sheets or macrofollicles in this kind of honeycomb appearance, with rare groups that show some nuclear membrane irregularities. You may not even have any sheets of cells. You may just have these rare clusters. Usually this diagnosis is made in paucicellular specimens, because you don't really have enough cells to kind of push it to 1 or to push it to 5. So often this is kind of one of the diagnoses in the middle. And our institution tends to differentiate nuclear atypia from other atypia. And so I'm going to end it now, because those of you who are answering, most of you got it right. So technically in the Bethesda grouping, AUS FLUS is 1 category. It's 3. However, when we've done studies at this institution, looking at nuclear irregularity only in paucicellular specimens versus microfollicular architectural irregularity only in paucicellular specimens, i.e. FLUS, right? Those behave very differently on resection. So as we'll talk about later, this is atypia of undetermined significance, which is predominantly small groups with nuclear atypia, but not flat out carcinoma. These end up having a higher risk of being papillary carcinoma than those that are just FLUS architectural atypia in the terms of microfollicles. Those tend to end up being follicular adenomas or follicular neoplasms, okay? And I'll give you those data later. But so for those of you who said AUS, correct. In this institution, we do differentiate AUS from FLUS. And so this is an example. I won't make you take the test again, because I basically just told you this is a paucicellular specimen that has microfollicular architecture, kind of like a rosettes, but the nuclei are very round and very bland. So this is FLUS architectural atypia. Yes, I know, RIP Alex Trebek, isn't that sad? Pancreatic cancer, right? Let's do pathology Jeopardy. Anybody interested? Just not today.
Megan, I think actually it was Ram. He had a PowerPoint set up like Jeopardy, and then it would be like, ooh, 400, GI, whatever. And then it was essentially like Jeopardy.
Nice. Awesome. All right. Maybe to culminate the head and neck section, we should do it over like, I don't know, some holiday hot chocolate or something.
Irish coffee.
Okay. So this is another example of an FNA that is, now we're getting into a very cellular category, right? So now we're like, all right, hopefully we can make a diagnosis because we have a lot of cells. These have both perhaps sheets and microfollicles, high cellularity. Maybe sometimes there's clusters kind of attached maybe along a vessel. But when you really investigate the nuclei, they are very round, very dark, and very regular. They don't have wrinkles, they don't have grooves, they don't have inclusions, right? So here we're in all right, I'm going to thank you for those of you who answered. I'm going to end and share. And so probably for a benign diagnosis, these are a little too cellular. So the thing is, we can confidently make benign diagnoses on FNA when usually there's lots of colloid and the nuclei are bland. But in cases that are colloid poor, are highly cellular, but the nuclei are bland, what is your concern? Your concern is a follicular neoplasm, and your concern is follicular carcinoma, right? Because usually follicular neoplasms are highly cellular, colloid poor, and the difference between follicular adenoma and follicular carcinoma can really only be made based on histologic examination of the capsule, right? So this would be category 4. Follicular neoplasm or suspicious for follicular neoplasm basically means the same thing. So stop sharing. Well done. So to put things in perspective, between atypia of undetermined significance, follicular lesion of undetermined significance, and suspicious for follicular neoplasm, our University of Chicago outcomes are different. So when we've taken only the flusses, the microfollicular architectures, those only end up having a malignancy rate of 7%. Most of them are benign adenomas. And this is really close to a benign FNA. A benign FNA has like a high end rate of malignancy at like 5%. So FLUS in our institution is very nearing benign, okay? Atypia of undetermined significance with that nuclear atypia ends up having a 33% malignancy rate. Most of them are PTC, which makes sense, right? Because you're catching that nuclear atypia, you just don't have a lot of cells. And sometimes PTCs can be what? Can be sclerotic, can be calcified, can be hard to sample because of that stromal fibrosis. And so it's not surprising that these end up mostly being PTCs. Now, suspicious for follicular neoplasm has similar rates of malignancy in our institution, about 25%. And this ends up being a hybrid of papillary and follicular carcinomas. If you think about it, sometimes the nuclear features are subtle and they're more obvious on resection. And so they end up being PTCs and having invasion. And sometimes the nuclear features are in fact bland, but they end up having capsular invasion and they end up being follicular carcinomas. Okay, does that make sense? If you guys want more information on our institutional data, I'm happy to give it to you. But we found these results. All right, so moving on to what are we likely to find then with a FLUS or a follicular neoplasm? These tend to be true follicular adenomas that are well circumscribed, maybe encapsulated, but maybe not. In this one, there's a capsule. The follicles are small, so-called microfollicles, right? So minimal colloid and lots of cells, but the nuclei remain small, dark, round, and regular, yeah? So this would be, for me, a microfollicular adenomatous nodule or a follicular adenoma. But again, whether it's clonal or not, sometimes can't be determined on histology, so adenomatous is fine. What about follicular carcinoma? As you know, you cannot make a diagnosis of follicular carcinoma on FNA. you have to have histologic evidence of mushrooming, capsular invasion, or vascular angioinvasion, right? So here's a classic example of what that capsular invasion looks like. You rarely see this perfect mushroom, but here's one example that we had. Sometimes you just see tumor cells on the other side of the lesion outside the capsule without a connection. That's also good enough. What you also want to look for is vascular or angio invasion. So this isn't small vessel like lymphatic invasion. This is invasion of large, sometimes muscular vessels in the capsule or next to the capsule. As you can see here, there's quite a large tumor thrombus. What you're looking for with vascular invasion is both endothelialization of the tumor plug, adherence to the wall with fibrosis, and sometimes intravascular thrombosis, where you might see platelets, platelet fibrin thrombi. All right. And if you come to my talk tomorrow at noon on NIFT-P, we'll learn a little bit more about concepts of invasion, et cetera. All right. So in this case, we have cellular clusters of oncocytes without much colloid and without really any inflammation in the background. Oops, I didn't want to share the results. Does anybody want to either type in, or the poll is being very slow today, answer the poll of what kind of lesion this might be, right? So on FNA, oncocytes, again, are going to have that cytoplasmic granularity with the mitochondria. They're going to have large nuclei with prominent nucleoli. And remember that oncocytes don't necessarily have to be, they can be a metaplastic reactive phenomenon in the setting of chronic thyroiditis. But they could also be something else. And so some of you, some are typing Hürthle cell neoplasm in the comments, some are voting. All right, so exactly. So Hürthle cell neoplasm, Hürthle cell lesion is in the context of a follicular neoplasm cytologically. So the nuclear features that you see in Hürthle cells, in oncocytes, should not be taken to represent the atypia that might direct you to a papillary carcinoma, right? So when we're calling something nuclear atypia in thyroid, it's usually indicating I'm worried about PTC. But if you're in the background of an oncocyte, those nuclei can be weird. They can be enlarged. They can be, as you see, irregular with grooves. They can have nucleoli, but put it all in the context of what you're looking at. And if you're looking at an oncocyte, you are more in a follicular lesion, a follicular neoplasm grouping than in a papillary grouping. So yes, in fact, you may put this in the bucket of a suspicious for follicular neoplasm, i.e. Hürthle cell neoplasm. The concept of interpreting Hürthle cell atypia is valid both on FNA and on histology, where we give a lot of leeway for nuclear change in oncocytic lesions because we know that oncocytes can do weird things, right? So here's an example of a Hürthle cell or an oncocytic adenoma. So those of you who said that, well done. These, again, are circumscribed or encapsulated. They're usually highly cellular, can have microfollicles, can often have trabeculae or cords where there really is no colloid. And certainly the cytoplasm is granular and pink, and the nuclei are enlarged with nucleoli, sometimes with grooves, sometimes with wrinkles. But again, in the context of oncocytes, we can be mindful that those are oncocyte atypia rather than papillary atypia. It's becoming clear that Hürthle cell neoplasms may be genetically different from other follicular neoplasms, right? In general, they're very similar. They're circumscribed nodules that are composed entirely of follicles that do not have papillary-like nuclei. So in a sense, they are follicular neoplasms, but genetically, they have more mitochondrial DNA mutations. They have some different chromosomal abnormalities, including duplications or losses. And some of them do still have RAS mutations, and we'll talk about mutations in a bit, but in lower rates than other follicular neoplasms. So just keep in mind that we're still learning more about Hürthle cell lesions. Okay. In this case, we have a highly cellular FNA. I'm not even going to do a poll here because I think we can all kind of understand where I'm getting. These have vessels with papillary-like fronds poking out. They have also sheets or clusters of cells with very dense, almost squamoid cytoplasm with enlarged nuclei that are wrinkled and perhaps overlapping. And oh, look, if you're on a pap smear, you might be able to actually find a pseudo-inclusion, right? So a pseudo-inclusion being where you can find an outer cell membrane, you can find nuclear chromatin, you can find an inner cell membrane, and then within that inner cell membrane, or I guess I should say nuclear membrane, you see the cytoplasmic contents, right? So these are intranuclear cytoplasmic pseudo-inclusions. These are quite specific for PTC. And then on the right, you just have some nuclear size and shape dyssynchrony. So yes, this would be malignant, this would be PTC. And so what do we expect to find on histology? Of course, you know, complex branching fibrovascular cores lined by these malignant cells with enlargement, elongation, grooves, chromatin clearing, pseudo-inclusions. I'm not going to go into, you know, gruesome detail about PTC because we've all seen it, or most of us have seen it. If you want more detail on PTC, come find me. We'll look at some slides in some of the next sections and review my YouTube video on the thyroid histology, which goes into a little more detail on all of the variants of thyroid neoplasms. Okay. Lastly, or maybe second to lastly, don't forget that there are lesions of non-thyroid follicular cells, right? So this has fusiform cells with more wispy cytoplasm. You may see binucleated cells that are kind of like looking at you. You may see little tiny chunks of amyloid. I'm giving it away. You do also see granular cytoplasm, but in a more kind of spindled or fusiform cell background. So those of you who thought it in your head, yes, well done. This is medullary carcinoma. So remember that medullary carcinoma is a tumor of the calcitonin secreting C cells, right? The neuroendocrine cells of the thyroid. These have characteristic neuroendocrine appearance with granular cytoplasm, not because they have mitochondria, right? But because they have neurosecretory granules in them. They tend to be in sheets and solid nests. They tend to have amyloid in the stroma. The amyloid in the stroma is actually just colloid, so, not colloid, calcitonin. So the calcitonin is what's creating that amyloid in the stroma. We should have phrased it as a question. Well, next time you do that, I'll phrase it as an answer. You phrase it as a question. All right. And the last case is showing clusters of large pleomorphic cells with wispy cytoplasm, with large nuclei, with prominent nucleoli. Not phrased as a question. What is anaplastic thyroid carcinoma? So highly possible. So this goes into our probably malignant, but something else category, right? And so you can have atypia of what's the word I'm looking for? Like cyst wall atypia. Arguably though, when you start to have without colloid, without other evidence of benign disease on FNA, with lots of cells that have highly pleomorphic nuclei, maybe even mitoses, you may want to start thinking about one of the aggressive thyroid carcinomas like poorly differentiated or anaplastic / undifferentiated. It can be very challenging to hit on poorly differentiated carcinoma on FNA because the cells look like follicular cells. So you may end up calling it a follicular neoplasm because it's very cellular. But anaplastic no longer looks like thyroid, right? It looks like wildly pleomorphic, those giant nucleoli, weird epithelioid morphology, sometimes even looks like squamous cell carcinoma. So this is what we're dealing with aggressive carcinomas, namely poorly diff or anaplastic. We can get into the criteria for poorly diff maybe when we look at the slides, but just know that this exists. In the past, it used to be called insular carcinoma because of its insular or solid growth pattern, right? No more follicles, no more papillae. Okay, so to evaluate, we've got all these diagnoses, right? We've got adenomas, carcinomas, papillaries, medullaries, poorly diffs. What are the mutations that are known to be found in them, and how are we going to be able to interpret the combination of an FNA diagnosis and a mutational profile? So we know that follicular neoplasms, right, follicular adenomas, follicular carcinomas, have predominantly things like RAS mutations, HN or KRAS. They can have BRAF mutations, but remember, it's not BRAF V600E, it's BRAF other, like BRAF K601E. So we just grossed one of these, Reham and Christine in the gross room the other day. Just FYI, this ended up being a follicular carcinoma. So we can look at those slides if you guys want. Also PAX8 PPAR gamma rearrangements. So the genetic overlap here between benign and malignant is challenging, because if you have one of these mutations, you know you are a follicular neoplasm. You just don't know if you are a follicular adenoma versus a follicular carcinoma, right? Unless you see that invasion grossly. Okay. If you're dealing with a BRAF V600E mutation, you are dealing with PTC. If you're dealing with a RET PTC rearrangement, an NTRK rearrangement, a BRAF rearrangement, the F is there for fusion, right? So there's various fusion partners with NTRK and BRAF. These also tend to be papillary carcinomas. Once you start getting aggressive mutations like TP53 and TERT promoter, you're now more likely to be in the poorly diff or undiff anaplastic spectrum. And remember that medullary carcinoma more specifically has RET gene mutations, not RET rearrangements necessarily, but RET gene mutations. Remember that both papillary and follicular carcinoma can transform to poorly diff, both can transform to anaplastic, and poorly diff can transform to anaplastic, right? So there's this kind of push or drive towards a potential higher behavior in any tumor of thyroid follicular cell origin. But unfortunately, not every thyroid tumor harbors a known mutation. There is this sort of dark matter, this unknown tumors that have none of these that still end up being cancer. So we're learning, but we don't know everything.
Hey,
Here's where molecular testing on FNA comes in. Does anybody have questions before I continue?
I just had a quick, actually really quick, only semi-related question. So the BRAF V600E mutation, I'm familiar with targeted therapies for that in other tumors like melanoma. There's vemurafenib, and I know there's all sorts of new, I don't know what this would be now, second or third or fourth or fifth generation targeted therapies against that. Is there actually utility in thyroid? I'm not familiar with that.
Yeah. So the first line of treatment for differentiated thyroid cancer is radioactive iodine, which is very good in most cases. Some tumors are radioactive iodine resistant or recurrent or metastatic. And it's in those metastatic, not just like to lymph nodes, but metastatic to lung, brain, whatever. If those are BRAF V600E mutated, yes, they do get BRAF inhibitor therapy. More often, it's a second line in differentiated cancers, but in undifferentiated or anaplastic cancers, it has been used as first line therapy. So some of you may remember the case we had not too long ago of a BRAF mutated anaplastic that was treated with the dabrafenib, vemurafenib, whatever. So yes, absolutely. As long as it's the V600E mutation specific, it can be a recipient of targeted therapy.
Thank you.
Okay. Losing my mouse. Okay, so there are 3 major commercial tests for indeterminate cytology in the United States. Remember, that's Bethesda 3, 4, and even sometimes 5 suspicious for malignancy. That's Veracyte's Afirma, that's Interpace's ThyGenX and Thyromere, and that's ThyroSeq. We send to Interpace here because of a number of reasons. One, they are shelf stable, so they don't require refrigeration for their reagents. They report both a microRNA profile and gene mutation / fusion. And we have a pretty decent working relationship with them. So as a reminder, all of these 3 companies have gene expression profiles that sort nodules into those with gene profiles more commonly seen in benign versus more commonly seen in malignant. So it's not a single gene mutation. It's like your microRNA and your messenger RNA is elevated or decreased in this grouping that is more similar to a benign nodule, okay? Most of these also report some single gene mutations or fusions that are present in thyroid neoplasms, some of those being specific to malignancy, like we said, like BRAF V600E, RET PTC, the MTC RET mutation. Others being not specific to malignancy, like RAS, PAX8, PPAR gamma, but specific to a neoplasm, right? So you usually have 2 buckets of results. One is this expression profile, and one is the actual point mutation or fusion or whatever that they report. If you have negative on both of those, you've basically taken your cytologically indeterminate nodule and given it a molecularly benign answer. So negative gene expression profile, negative mutation, you have anywhere between a 4 and 5% risk of malignancy in the end. So you've basically put it into a benign category. These patients can successfully avoid surgery if they do not want it. But if you have a positive result in either of those categories, it is highly variable and depends on what is identified. So what are we dealing with? Come on, next slide. So if you have, again, a negative mutation and a negative gene expression profile, you're basically benign. You don't have to undergo surgery. If you have a positive mutation that is of a follicular neoplasm sort, right, like RAS, like BRAF non-B600E, like PAX8 PPAR gamma, you're dealing with maybe a follicular adenoma, maybe a follicular carcinoma, maybe a NIFT-P, but these patients generally will undergo diagnostic lobectomy for definitive diagnosis. If you have a positive mutation that's in a carcinoma, BRAF V600E, RET PTC, NTRK, right? I'm starting to sound like a broken record, or something aggressive like a TERT promoter. You're probably gonna get, if not a diagnostic lobe, at least a total therapeutic lobectomy or a therapeutic total thyroidectomy, depending on the extent of disease. Remember, we said that low risk, small cancers might just undergo a therapeutic lobe, but higher risk, larger cancers might undergo a therapeutic total, okay? What if you have a positive gene expression profile, but a negative mutation? Meaning your microRNA looks like you might be malignant, but you don't have a mutation that's specific. Well, it still could be cancer. So these patients, again, undergo diagnostic lobectomy for definitive diagnosis. These are kind of the buckets that I put things in when I'm looking at the FNA results and the molecular results. Does this help?
Yes.
So our cytopathologists triage these cases at FNA, and they will take extra vials, right, for molecular in cases that they think are going to end up being indeterminate or are weird clinically otherwise, okay? And so I look at the results of the molecular all the time when I'm signing out the resection. Okay. Now that the person has undergone resection, do we do frozens? Do we do intraoperative evaluations of thyroid? So does anybody have questions again? Sorry, I hope I didn't interrupt anybody.
No.
No, okay. What is no? Exactly. So frozens used to be done for thyroid historically, and it has been determined that they are useless for the most part. So intraoperative diagnosis of thyroid is usually not going to change your FNA diagnosis and is not going to change intraoperative management. If a frozen is requested on an unexpected nodule or something that is going to change intraoperative management, we request that you do perform a smear of all thyroid nodules that you may get. Parathyroid, you don't need to, right, so parathyroid is different. They're usually looking to identify, is it parathyroid tissue or not? because they want to know if it's just a lymph node and they're safe having taken it out. If it's parathyroid tissue, they don't want the patient to be hypoparathyroid, right? But this is different from making a diagnosis of a thyroid follicular nodule on frozen. So as you know, nuclear features and architecture are all important, and freezing destroys nuclear features. So we request you to take a smear of the fresh nodule. And by taking a smear or a touch prep, I don't just mean cutting the nodule open and blopping it on a slide. And so all you see is like blood and colloid. What I mean, and I'm happy to show this with you in the gross room together, is opening up the nodule, blotting it off to remove the colloid and the blood and the water or whatever, and actually taking a scalpel blade and scraping the surface of it, blopping that scrape on the slide, and then smearing it as if you were actually in an FNA. The reason for that is because epithelial malignancies, even spindle cell malignancies, if you're dealing with a spindle cell lesion, don't just drop off the tissue like lymphoid cells do, right? Because they have desmosomes, they have intercellular bridges, they are arranged in architectural patterns that don't just like drop off the tissue. So in order to get them, you have to scrape them off, put them on a slide and smear them. And so once you do this, should you then pin out the specimen? Yeah, so, or gross it fresh, either. So what we've done for both thyroid and salivary that require intraoperative evaluation is, rather than serially sectioning it like we normally do grossly, we've on permanent, I should say, we've actually taken a somewhat different approach, is to bisect it longitudinally, open up the face, right? So now you have two halves, and take your smear or your frozen from that face, because then, like they do with the tissue bank prostates, right? Then you can actually pin it face down and pin the periphery or pin the capsule, even though thyroid doesn't have a capsule, right? Pin it to wax. And now you've effectively preserved the remainder of the periphery of that tissue, because, and you've once you cut into it, it retracts, right? That tissue plane, like you're saying, that tissue plane around the thyroid gland, the non-capsule, just retracts like crazy. And so in order to minimize retraction, make as fewest cuts as possible. And usually that's one longitudinal cut. Hopefully that answers your question. So both for salivary and for thyroid, that's what I would potentially recommend. We've seen cases from consult clients who do completely serially section it fresh at the time of frozen, and it introduces a lot of artifact. Sometimes squeezing artifact, where it now looks like there's capsular invasion where there may not have been. There were studies that actually did this freshly and introduced tumor cells into vessels just by manual palpation. So there can be artifactual vascular invasion. Like, I'm not kidding. This is weird stuff. So I really don't recommend thyroid frozens. Okay. Keep moving forward, slides. All right. When you do your smears, you can either choose to stain them in H&E. If you do, place them immediately into alcoholic formalin and just stain regularly with H&E and cover them immediately. If you want to do a diff quick smear, more similar to what they do in FNA, you have to let that slide air dry completely, right? Then stain it with the heme diff quick, and then let it air dry again before cover slipping it. It may look a little blurry, but it's okay. You can do either technique. Just as an aside, remember, we sometimes use the diff quicks for invasive fungal sinusitis. Here's instructions for how to do it if you ever are in that pickle. Okay, I won't go over it though. So in the last few minutes, we'll talk about some grossing techniques. So overnight fixation of thyroid is strongly encouraged prior to sectioning because it preserves the nuclear features much better. It preserves the integrity of the peripheral tissue plane, right? Non-capsule. It preserves the integrity of the tumor capsule, right? So if you're dealing with a tumor inside the thyroid, that tumor might actually have a capsule. And so you're not only fixing the edge of the gland, you're fixing the edge of the tumor, you're fixing the nuclei. It's all very, very good and helpful. When you approach a thyroid, as I always recommend, check the ultrasound, check the FNA results to look for size, location, FNA diagnoses, and that's going to help your grossing. So just as a reminder, you may get a lobe or a hemi, and you may get a total. If you're dealing with a lobe or a hemi, we really only ink that cut isthmic margin a different color because that is a different margin than the periphery, right? That is that plane is in continuity with the rest of the gland, whereas the peripheral margin is in continuity with the neck tissues of the patient. So there's different margins there. In general, we want a section perpendicular to the long axis. If you have a long isthmus, you can certainly section it sagittally. If you have a very short or a very narrow or kind of no isthmus, don't worry about doing, sagittal sections. You can just do the two lobes as seen on the bottom right, as if they were just two lobes stuck together. So that's totally fine. You don't have to do every isthmus longitudinally. So I've gone over this with a few of you, haven't really put it into practice uniformly yet, but I want us to all think about how to gross follicular neoplasms, flusses, follicular neoplasms, or lesions that have follicular genetics, right? So follicular adenoma versus follicular carcinoma depends on evaluation of capsular and vascular invasion. So what is the best way to fully evaluate the capsule? Sorry, I can't turn this into a Jeopardy. If you think about it, your best way to see the entire capsule is to treat the tips of the nodule as tips, right? And to section them perpendicularly. So depending on where the nodule is in the gland, up, middle, or lower, I don't necessarily care as much about the tip of the gland as I do about the tip of the nodule, if that makes sense. So when we did this BRAF K601E thyroid the other day, we basically perpendicularly sectioned the majority of the gland. We made the cuts, we made the cuts at the tips of the nodule larger, and then did those perpendicular so that we could see the edge of that nodule and see if there was capsular or vascular invasion in those poles. So I think this should make theoretical sense. This is the best way to evaluate the tips of the nodule. Here's an example of an alternative method. If you can't figure out where the nodule begins and ends based on your sort of overall gross exam, then you can bisect it longitudinally, open it up, right? And then you can say, oh, the nodule begins and ends here. Great. I'll do most of my sections across, but then I'll do my sections at the tips perpendicularly, if that makes sense, right? So there's many ways to skin a cat, but ideally, if you're serious about having this be a follicular neoplasm and evaluating for the capsule, these are the ways to do it. This is called the modified transverse vertical method because you can, my internet must be slow, because of obvious reasons. And this allows you to potentially identify capsular or vascular invasion at the poles that you otherwise would have missed by just putting those as like on FOS, okay? 859. So one kind of last thing I'll say about gross evaluation is now gross identification of extrathyroidal invasion is important for staging. In the past, we used to upstage anything with extrathyroidal extension, microscopic, gross, anything. Now, really, it's only macroscopic extrathyroidal invasion, which is a combination of both what you see when you cut it and what the surgeon sees intraoperatively if it's like stuck to skeletal muscle, right? So if you see microscopic ETE, you may want to confirm with the surgical operative note whether that was also seen grossly as gross ETE. And when you are looking at the thyroid grossly, you want to look for skeletal muscle at the edge. You want to look for fat at the edge. You want to see if there's any potential gross invasion on our cut sections into skeletal muscle and document that in the report. So I think we've talked a lot about calcification and decalcification in prior lectures. especially with the BST. I will just remind you that thyroid nodules can be calcified, right? Whether they're peripheral eggshell calcifications in a follicular neoplasm, whether they're internal stippled calcifications in PTC, whether it's actual frank ossification in a PTC, right? Or whether it's a metastasis to bone. So just please remember that neoplasms, lesions, just expect molecular testing to be required. And always think about giving us undecalcified tumor or giving us tumor decalcified in EDTA that preserves the nucleic acids. So I think I've hammered this home in prior lectures, but just as a reminder, it's applicable across specimens. Sometimes we do molecular testing on our FFPE blocks if it's not already been done on FNA, sometimes for diagnosis, sometimes for prognosis, like an aggressive TP53 or TERT promoter mutation, and definitely, as suggested before, for treatment, whether it be a BRAF V600E inhibitor or an NTRK inhibitor. So in summary, check all of your boxes. Make sure you check the imaging, make sure you check the FNA, make sure you check whether molecular has been done. Do gross correlation. Always call me if you need me. Hopefully, don't be afraid. I apologize, we don't have time for the histology, but what I will do is there's a few slides in this link, but I will add more. I'll add more slides to this link, and that's what we will do next session. I don't think the next session is, unfortunately, things have been rearranged. So I think our next thyroid isn't until early December. But if you have any questions or comments in the meantime, please come find me. Am I still sharing or not? There, okay.